Thanks, Stephen, and good morning, everyone. All right, so today we have a very distinguished speaker. Today we will have Dr. Elizabeth Matsui, Associate Dean for Faculty Academic Affairs, Dell Medical School, and Director of the Center for Health and Environment Education and Research. Elizabeth Matsui is a pediatric allergist, immunologist, and epidemiologist, and a leading international expert on environmental exposures and their effects on asthma and other allergic conditions. Her work is focused on housing-related exposures in particular, and her team identified endemic mouse infestation as the major environmental cause of asthma-related emergency department visits and hospitalizations among children in Baltimore and in other similar cities in the U.S. Her group followed up on this observation by developing and testing interventions to address infestation, which include integrated pest management strategies for individual households and housing policy interventions. She is a fellow of the American Academy of Allergy, Asthma, and Immunology, serves on the editorial board of the Journal of Allergy and Clinical Immunology, as chair of the section of Allergy and Immunology of the American Academy of Pediatrics, and as a member of the National Academies of Sciences Standing Committee on medical and epidemiological aspects of air pollution on U.S. government employees and their families. Please welcome today Dr. Matsui.
Thank you so much. And it's nice to see friends in the audience. And I have, I think, about 30 slides or so. And sometimes I know people are reluctant to speak up on Zoom, but I'm totally fine, having more of a discussion than a formal presentation. So if people feel so inclined, feel free to chime in, raise your hands, or what have you. Hopefully, I can't see everybody on on my view, but I can see many of you, but it's also fine to interrupt. So, as Jay said, I essentially have focused on the intersection of environment and asthma disparities. And when thinking about environmental exposures, most of what I have focused on over the years has been airborne exposures. And the work has kind of culminated in this concept that's related to the neighborhoods we live in determine what's in the air that we breathe. So I'm going to lay out kind of more recent work that's built on that work initially that focused on mouse infestation. So there is clearly a spatial pattern to asthma morbidity, and this is not unique to any one city. Here you see Travis County. So this is a map that depicts emergency department rates for asthma at the census tract level. This group is very familiar with differences between Eastern and Western Travis County and the characteristics of the population in Eastern Travis County. The middle map there is of the San Francisco Bay Area, clearly a spatial pattern that has emerged there. And then the next map on the right is of Baltimore City, and there's a distinct spatial pattern. This is a map of asthma hospitalizations, and there's a butterfly pattern that you see there. And when you look another layer under, oh gosh, I have WebEx trying to update. Okay, if you look another layer under, and I kind of alluded to this, to understand if there are correlations, spatial correlations between asthma emergency department visits or some measure of morbidity and other features of those neighborhoods, it's not surprising that those neighborhoods also have a higher percentage of residents who live below the federal poverty line and a higher percentage of Black or Latinx Hispanic residents. And you can see in these maps, so this is a collaboration with Catherine, who I see on the call, Corey Ziegler, who used to be at UT, who's a statistician, who's now at Brown, and then a graduate student at the time, who's now an instructional faculty member, Raz Zarate. We used health data that's available through the Texas Department of State Health Services to understand the patterns of asthma morbidity in Travis County. Overall, we see disparities here with Black children having an eightfold higher rate of asthma emergency department visits than their white counterparts. And then we also see similar disparities, not quite as large a magnitude between Latinx Hispanic kids and white kids. And then we see this patterning in Eastern Travis County with the highest rates of asthma emergency department visits, higher rates of poverty, and higher percentages of Black or Latinx residents. And so this is, no accident. And there's another layer here, which is that there's spatial correlation with environmental factors. So this is a map of Cincinnati showing spatial correlation between housing code violations and repeated emergency department visits or readmissions for asthma, so asthma hospitalizations. This is a map of Washington, D.C., showing the asthma emergency department visits that are attributable to PM 2.5. So they're here in southeastern Washington, D.C. Here is a map of the 5 boroughs of New York City, depicting high prevalence versus low prevalence asthma neighborhoods, and then mouse and cockroach allergen concentrations in homes from those neighborhoods. And there's correlation between asthma prevalence and higher cockroach and mouse allergen levels. And then there's been a large volume of literature that links or associates neighborhood level violence or reported safety with childhood asthma. So why are there these spatial correlations? We have asthma morbidity measures, racial and ethnic neighborhood composition, poverty, and environmental features. And at least in my world, I come from a biomedical world, which has long not been very informed by the social sciences or even public health perspectives. This is the causal framework of the work that was being done, not exclusively, but by and large, when I started doing this work in, around 2000 or so, was that racial and ethnic identity caused asthma or poor asthma outcomes. And what has become very clear over time, and I think the biomedical research community is starting starting recently to appreciate this, is that there's a correlation between racial and ethnic identity and asthma burden, but that's not a causal relationship. And the causal relationship is depicted below, which is this history of Jim Crow laws and racial covenants leading to highly segregated neighborhoods. And then those neighborhoods were stripped of opportunities for wealth through housing discrimination. And then on top of that, there were zoning laws and other ordinances that led to hazardous environmental conditions, so environmental racism, leading to the neighborhoods that we see across the US, where there's concentrated poverty, environmental hazards, and high rates of segregation in those neighborhoods. And so all of those factors come together, and those are the neighborhoods that have high rates of asthma or burden of asthma morbidity. And so the story in Baltimore, and I'll tell the story in Austin, although this audience is familiar with this, is that in 1910 in Baltimore, a Black man who was a Yale educated lawyer, and I say that because that tells you this was not about class, it was about race, wanted to move into a predominantly white neighborhood. This led to Baltimore implementing a Jim Crow ordinance that led to this article in the New York Times in December of 1910. Baltimore tries drastic plan of race segregation, preventing someone who is Black from moving into a predominantly white neighborhood and preventing someone who is white from moving into a predominantly Black neighborhood. And so this is an example of a segregation force. This audience knows about redlining, so redlining then followed. And when you look at the Baltimore City pattern of redlining, you can see this butterfly pattern that I highlighted in an earlier slide. The Fair Housing Act was passed in 1968, which was very helpful. There's still housing discrimination that goes on in this to this day, however. And then there's another layer, which is disinvestment. So this bar graph is from the Baltimore City Office of Equity from 2017, and it shows the dollar amount invested in different neighborhoods based on the level of poverty of those neighborhoods. So the highest poverty neighborhoods have the least amount of investment. And then this is the map I showed you in an earlier slide. This was in the Washington Post, actually. They created this
Melissa,
map of
I'm not
asthma
seeing the
hospitalizations.
slides.
I'm sorry.
I'm not seeing the slides. Is everybody else seeing them?
Yes, I see them.
Yeah.
Yeah, I've got them.
Okay. Something weird going on. Sorry to
That's
interrupt.
okay. So you can see there's a butterfly pattern, and this was around 2017 or 2018. And so the redlining, which is also the segregated neighborhoods. So the poverty, high degree of segregation, and what I don't show here are environmental factors, but all of those forces that happened more than 100 years ago are manifesting in this excess burden of asthma in these communities that live in those butterfly area neighborhoods. And so Austin has this similar history. The Koch and Fowler City Plan was implemented in 1928, and this created an African American district, which was the only part of the city where African Americans could access schools and other public services. A collaborator in architecture, Liz Mueller, has also made the point that this was public services included sewage systems. Redlining also happened in Austin, and one of the redlined areas was the African American district that was created by the Koch and Fowler City Plan. So again, a segregation force, a force that strips opportunities for wealth and promotes poverty. And a very important point that housing discrimination targets all racialized people. So there's a story, similar story for the Latinx Hispanic community in Austin. So Austin built the country's first development to receive allocations from HUD in 1939. It was placed in East Austin. So if you think about the timeline, this is about a decade after the Koch and Fowler City Plan, which created this neighborhood for Black residents that was in East Austin. So now Austin is putting more public housing also in on the east side. And the stated intent was to provide low-cost housing to the Latinx Hispanic population, and that population had been living in pockets that were scattered across the Austin area. The other thing that happened is that while this population was considered white, so they were not initially affected by the discriminatory language and racial covenants. The language and racial covenants shifted to basically minoritize this population or racialize them. So that language shifted from no people of African descent can live in this neighborhood to Caucasian only, thereby racializing that population. So then that population gets swept up in housing discrimination. And there are these great pictures of the spatial distribution of African American and Mexican American households. It's very jittery in Austin. And so this became I-35. So this is 1880 on the left, 1910 in the middle, and then 1940 on the right. And you can still see Clarksville, which sort of was the only other African, it was a freedmen's neighborhood, and so that persisted. But then you see this shift and consolidation to the east side of I-35. And there's a layer of environmental racism. So zoning protections were permissive in neighborhoods that you see are colored pink here. And so now you have a layering on top of segregation forces, housing discrimination through redlining and other forces. And now you have permissive environmental zoning. And when you zoom out and you look at a map of Travis County and the locations of air pollution sources, it's no accident that they are on the eastern side of Travis County. The darker blue the census tract is, the higher the rate of neighborhood poverty. So that background kind of begs the question of, are air pollution levels different from one neighborhood to another in Travis County or the Central Texas area? If they are, do they seem to correlate with the burden of asthma emergency department visits in a neighborhood? So neighborhoods with higher air pollution, do they have higher rates of asthma emergency department visits? And then do those differences in air pollution, if they exist between neighborhoods, explain racial and ethnic disparities at the neighborhood level in asthma emergency department visits? And so I'm going to walk you through this slide. So this was a paper led by Sarah Chamelis, who's a research associate in our group. I want to pause and talk about how it takes really a multidisciplinary approach to do this work. Sarah is an environmental engineer, so she got her PhD here. And within that field, she has expertise in air pollution exposure assessment. And then this work was done in collaboration with a biostatistician and then in collaboration with myself. So we brought to bear clinical expertise, epidemiology, biostatistics, environmental engineering, and air pollution exposure assessment. So in this, the background of this study, it has been well established that there are small differences from one neighborhood to the next in air pollution levels. It had not really been shown whether those differences mattered in terms of neighborhood burden of any kind of health outcome that we know is attributable to air pollution. And certainly it hadn't been shown that those differences in air pollution mattered in terms of racial and ethnic disparities in some sort of health outcome. And part of the reason why this is that our regulatory framework for air pollution is focused on the county level. And so a county is considered in attainment with federal standards. So for example, for PM 2.5 or fine particulate matter, if the annual average PM 2.5 over that county is below that standard, which is now 9 micrograms per cubic meter. But within that county, there are going to be differences and variability in air pollution concentrations. They may not be large, but they very much likely exist. It would be bizarre if they didn't. And so a question is what is the magnitude of those differences and do they matter? And so she looked at asthma emergency department visits at the census tract level for the 5-county Austin metro area. And what you see in the top figure is the incidence rate ratio that incidence rate ratio is 1.5. And it is the relationship between the percentage of residents in a census tract who are Black versus the asthma emergency department rate in that census tract or that neighborhood. So for every 10 percentage point increase in the Black population, we observe a 51% increase in the asthma emergency department visit rate. Then what she did was she adjusted for neighborhood level air pollution. And so NO2, PM 2.5, PM 10, SO2, and then all pollutants. These are not, when she says all pollutants, they're all the major pollutants, criteria pollutants that are regulated. So it's not the whole universe of air pollution. And then that disparity dropped. And so that disparity then became 1.39. And so air pollution seems to explain about 24% of the disparity in asthma emergency department visits between neighborhoods with higher percentages of Black residents versus those with lower percentages of Black residents. And so this was really the first work that showed that these differences that had been described in other areas of the country mattered in terms of a health outcome because they're not huge differences in air pollution concentrations. and matter in terms of population level disparities. And then the figure below is the same exact setup, but for share of the residents in a census tract who are Latinx or Hispanic. And then air pollution attenuated that disparity in asthma emergency department visits between neighborhoods with higher share of Latinx or Hispanic residents versus lower share by about 32%. So this suggests that if you were able to intervene on a neighborhood level and lower air pollution levels in neighborhoods that experience higher air pollution levels, and that those are the neighborhoods that have higher percentages of residents of color, that you would be able to shrink asthma disparities. So how do we intervene? You can target the neighborhood, and there are all sorts of approaches to urban planning, investment, green spaces, tree cover, vacant lot management, figuring out, you can put scrubbers on certain air pollution point sources. You can, when you're citing new potential air pollution sources, not cite them in vulnerable neighborhoods. You can do it through housing policy so that low-income housing is not concentrated in a particular area, and mitigate gentrification. All of those are really important. I'm going to talk about housing mobility, which is an intervention where people move from neighborhoods with high levels of concentrated poverty into better resource neighborhoods. This is not to say that a place-based intervention is not important. It's critically important. But I'm going to focus on this because this is data that we have and the study that we did. So the Mobility Asthma Project was a prospective cohort study of 140 children with asthma. They were enrolled in a housing mobility program that was operated by the Baltimore Regional Housing Partnership, which is a nonprofit in the Baltimore area. So we started recruitment in July of 2016, and then the main analyses stopped at the start of COVID. The kids who were enrolled were 5 to 17 years of age. They had to have persistent asthma or have had an asthma exacerbation the last year, which is typically they need to take oral prednisone or a prednisone burst because they're having such a severe flare of their asthma. They didn't have to be allergic to anything in particular, and this matters because given what we found about mouse infestation, one of the questions was, if families moved, what happened to mouse allergen levels, and would that improve their asthma? But this was really not about focusing on a specific allergen or only allergic kids where the allergy triggers the asthma. It was more of a general population of kids with asthma. So BRHP was started as a result of a class action lawsuit, Thompson versus HUD. So this lawsuit, the allegations were that the Baltimore Housing Authority and HUD had violated the Fair Housing Act in the way that they administered their housing voucher program. And there is a legal concept, which is that even if there's not an intent to discriminate, if the impact and the data, the evidence shows that there's discrimination that's ongoing, then that meets the criteria, the legal criteria for violating the Fair Housing Act. And essentially the concept was Baltimore, so the housing voucher eligible population in Baltimore is almost entirely a Black population. And that population was almost always, if they had a housing voucher, moving a block away to an equally distressed neighborhood when there was housing in better resource neighborhood that was housing voucher eligible, that they were not moving to. And so the legal argument was that clearly in the way the program was administered, people were not given an opportunity, if they so chose, to move to these other neighborhoods. So there was funding set aside and earmarked federal housing vouchers that stood up BRHP, and that BRHP used to help families who were interested in moving out of their neighborhoods to move. So this number is actually up to about 7,000 families that they've helped move. And so they provide families with extensive pre-move housing search and post-move counseling support. If you don't have transportation and your job is in Baltimore City, but you're moving to Baltimore County, then there's a lot of grappling with what that's going to look like for your job and transportation. And so they support the families in sort of thinking through and strategizing about what would work best for them. There are massive changes in the poverty rates of the pre-move versus post-move neighborhoods. So the average pre-move neighborhood poverty rate in 2018 was 37%. Post-move was about 8%. And then on the left, you see a very typical picture of East or West Baltimore in those butterfly regions where there's an occupied row home right next to a vacant row home. And then the other pictures are examples of housing that families would be moving to through this mobility program. So out of the 140 participants we enrolled, 122 moved. And so we had observations in a pre-move time period because they would take 6 to 9 to 12 months in the counseling period before they moved. And then we followed them for a year afterwards. And this map basically shows the census tracts of where they lived before and after moving. And so the before moving pictures on the left, and you can see, and I don't know if you can see my pointer, hopefully. This is Baltimore City right here. In the middle. And so most families lived in Baltimore City, and there are darker blue census tracts there because the darker the blue, the higher the poverty rate. And then here on the map on the right, fewer people lived in Baltimore City. There are some. They lived in these red outline census tracts, and then those red outline census tracts are less likely to, be dark blue, essentially. And so the other differences between the pre and post move neighborhoods. So pre-move neighborhoods, about 20% of the neighborhoods had 20% vacant homes. Pre-move neighborhoods, post-move neighborhoods had less than 5% homes vacant. Owner-occupied housing was 30-some% in pre-move neighborhoods, almost 70% in post-move neighborhoods. Families living below the poverty level, you can see, is 30% or almost 30% in the pre-move neighborhoods versus 5% or less in the post-move neighborhoods. There are big differences in the racial and ethnic composition, and I'm not going to cover this specifically, but there are teams or groups that study the potential risk of discriminatory experiences and changes in neighborhood support, perception of neighborhood support or neighborhood, social cohesion with moving. This did not turn out to be, we looked at discrimination and you'll see in a little bit, we looked at neighborhood factors, and for these families who moved, all of whom were Black, their discriminatory experiences and experiences of neighborhood social cohesion either didn't change or improved quite a bit. And then the last set of bars there are the percent of the census tracts that were historically redlined neighborhoods. So over about 35% in the pre-move neighborhoods have been redlined. So I know this is not a clinical audience, so I'll put this in context. So we had a propensity score matched comparison group, which was a cohort from an NIH-sponsored inner-city asthma consortium birth cohort that was recruited from similar neighborhoods and in Baltimore and then in 3 other cities. And so these primary results compared to understand or estimate the effect of moving on asthma exacerbations, had a comparison group, which was this propensity matched comparison group or control group that did not move versus this group that did move. So we observed a 50% reduction in the odds of having an exacerbation. And to give you a sense of the magnitude of that improvement, The mainstay therapy for asthma is inhaled corticosteroids, so an anti-inflammatory inhaler that you take every day to control inflammation in the lungs. This is a larger effect than those medications. And so I think this speaks volumes about people didn't change, their identity didn't change, their neighborhood changed, yet they had these massive improvements in their asthma. So why was that? What might have mediated the improvements? So there are allergens on the table on the left. So there wasn't really a change in home allergen levels. So we collect dust from the homes and we use an immunoassay to quantify allergen in home dust. The dog allergen levels increase from pre to post move homes. Dust mite allergens increase. So that was something we very much had observed, was that in suburban Baltimore, there's much higher levels of dust mite than in Baltimore City. And cockroach allergen and mouse allergen decreased, but these did not mediate the improvements in asthma that we saw with moving. We also measured indoor air pollution, so indoor PM 2.5 and PM 10, and we asked about the number of cigarettes smoked in the home. These decreased, not by large magnitudes, but they did decrease some, and they also did not appear to explain the improvements in asthma with moving. And what did seem to explain the improvements were factors that were stressors or stress-related factors. So social cohesion increased, and explained, all of these each explained about 25 to 30% of the total effect of moving on improvements in asthma. Reported neighborhood safety increased from pre to post move neighborhoods, also was a mediator. And then urban stress decreased and seemed to mediate the effect of moving on asthma. Parental depression did improve, but did not seem to mediate the improvements. And then discrimination or reports of discrimination decreased when they moved, but that also didn't seem to mediate the beneficial effects of moving on asthma morbidity. So then what happened to outdoor air pollution? So this is a paper now that's been fully developed and is under review, and this is led by Sarah Chambliss. So you can see this is total PM 2.5 decreased when people moved from their pre-move to their post-move neighborhoods. And then these specific things, black carbon, organic carbon, nitrate, ammonium, and sulfate, are specific components of the particles themselves. And some of these decreased to a greater extent than the others. You notice black carbon decreased quite a bit, and that's a marker of traffic, roughly. Organic carbon decreased, and then you saw some other decreases in the other components. At the end of the day, when we completed our analyses, it looks like air changes in air pollution also contributed to mediating the effects of moving on improvements in asthma. So what about lung function? So let me walk you through this because this can be kind of complicated to absorb. So on the left here is a histogram of FEV1. I'll explain what that is in a minute. And for Black adults in the US, so that's the blue bars, and white adults in the US, so those are the white bars with the red outlines. And so on average in the US, Black adults have this measure of lung function, FEV1, that is 500 milliliters lower than white adults. Black children, which is not this graph, have on average an FEV1 that is 10% lower than their white counterparts. So FEV1 is the amount of air that you can blow out in a second after you've taken a big breath. And so when I'm in clinic seeing patients, I talk about this as, if you take a big breath and you imagine your lungs are balloons, and you then have to blow out as hard and fast as you can through a boba straw, you will be able to blow out a pretty large volume of air in a second. If you're trying to blow out or exhale through a cocktail straw, and a cocktail straw represents an airway that's closed or smaller than the boba straw, then you will not be able to blow out as much air. And so FEV1 is a measure of the amount of air you can blow out in that first second. So because of this distribution of FEV1, we have reference equations for what we would expect to be normal for someone that incorporate race and normalize a Black person having lower FEV1 than a white person. And what I mean by that is when you come into a clinic and you have lung function testing done, and this is changing now, but in the not so recent past and still in many clinical settings, you enter someone's height, their gender, their age, and their race. And there are reference equations that are based on NHANES data actually that will say, okay, for this person who is, Black and female and 40, normalize lower lung function in Black people in the US. And so there's a large question then about why do Black people in the US have lower lung function that had been kind of ignored, and it was assumed to be normative. Separately from this, we published a paper that has helped provide the evidence base to change the reference equations that are used so that race is not a feature or incorporated into those equations. So is there evidence that this could be the case, that there are neighborhood factors or environmental exposures that could explain these disparities in FEV1 between Black people in the US and white people? And there is. So when we did our work related to mouse allergen and attempted to try to intervene with integrated pest management, we saw that there was a group of kids that had sustained reduction to mouse allergen. And all these kids in the study were allergic to mice and had persistent asthma. And those kids who had a sustained reduction in mouse allergen over a year had a larger increase in their FEV1 over that year than the kids who did not have a sustained decrease in mouse allergen. And so this is tricky to think about. As kids are growing, their FEV1 is growing. And if their FEV1 is not growing as quickly at as high a rate, they're going to reach adulthood at a lower FEV1. And so what we found is if they had less mouse allergen exposure, they had 75 to 100 milliliters greater FEV1 growth in a year than those who didn't. And when you're an adult, you lose about 25 milliliters of FEV1 each year. So these kids recouped 3 to 4 years of adult lung function loss. And this matters because kids with asthma, about 3/4 of them have an abnormal lung function when they reach adulthood. There's a fixed decline. And so that FEV1 that they reach in adulthood predicts their risk of COPD and actually eventually mortality as well. So this study suggested that this environmental exposure can shape the trajectory or growth of FEV1 in kids. And so if Black kids are disproportionately exposed to mouse infestation because of all of the historical factors that I outlined, then maybe the environments in which these kids grow up explain the disparities in lung function. So we have looked at lung function trajectories in the Mobility Asthma Project. This is preliminary data. We got a renewal on the R01 to continue to follow them because this was not statistically significant. But here you see the trajectory in FEV1 growth going forward. If they hadn't moved, and at the point of move, they had an increase in their FEV1 growth by 45 mLs. And I know we're getting low on time, but I do also want to highlight work of Darlene Babnani, who is an assistant professor in the Department of Population Health and is a part of our group, who is an infectious disease epidemiologist and has been interested in understanding whether there's a role of disparities in respiratory infections that explain disparities in asthma exacerbations. So the major driver of asthma exacerbations are upper respiratory tract infections. And so in this paper, which was an analysis of NHANES data, She shows that Black and Mexican American kids have about a twofold greater risk of having a URI or an upper respiratory infection than other groups. So this suggests that this could explain some of the disparity in asthma exacerbations. And she tried to answer that question directly by looking at electronic health record data before and after the pandemic for asthma exacerbations. And so what you see here is the relative risk, basically, of asthma emergency department visits in Black versus white kids in 2019. So it hovers somewhere between 5 and 7. And then in the spring of 2020, when there was virtually no circulating virus. So if viruses are a major driver of racial and ethnic disparities in asthma exacerbations, when they go away, you would expect that the disparity in asthma exacerbations would go away or shrink quite a bit because there would be a greater reduction in risk among populations that have excess asthma exacerbation risk, so Black and Hispanic populations. And indeed, this is what happened to the Black-white disparity in that spring, and then it bounced back up, suggesting that there's some vulnerability or susceptibility to URIs associated with race and ethnicity that might explain these disparities in exacerbations. So she followed this up by doing a secondary data analysis of a study we had in Baltimore where we collected nasal samples and they were analyzed for the presence of upper respiratory virus instead of just a questionnaire that asked about cold symptoms. And what she found is that as with cockroach allergen in the home and mouse allergen in the home, those were associated with a higher risk of having a respiratory virus detected in the nose and having cold symptoms with it and having lower respiratory manifestations. So FeNO is a measure of pulmonary inflammation, and then FEV1, as you know, is lung function. So cockroach allergen and mouse allergen exposure, which are part and parcel of neighborhoods with poor housing that are highly segregated and have concentrated poverty, seem to be associated with greater risk of having a cold viral infection with upper respiratory symptoms as well as asthma manifestations. And I will, because I want to leave time, I'll just skip these. So the social scientists in here, maybe you're happy or not, but this is a slide that I always include when I give talks to a biomedical audience about reification. And this was this is from an article in the New York Times, actually written by Dr. Danielle Carr. So I will stop there. Questions, comments?
Thanks so much, Elizabeth. That was very informative. And I was just wondering because Baltimore Metro is notoriously bad when it comes to its air quality. You know, the power plants, the bay breezes. It does seem like currently the best way to help people is to move them out of that metro area, and that seems to be what the program is about. But what can be done to help the people who are unable to move or without any transportation because they work in the metro area? What can be done about that?
Yeah, I think that's a fantastic question. And, this issue about moving is an understandably super sensitive issue because not everyone wants to move. It can evoke strong feelings related to gentrification and forced moving of all of the forces of segregation. So I do want to say that this is all, there's a long waiting list. So there is a housing voucher program where people don't have to move to better resource neighborhoods, and that these sorts of programs absolutely do not obviate the huge imperative to address the neighborhoods themselves and for place-based interventions. And so, I mean, there's a whole, I think I'm not a policy expert, but if you start to break down all of the environmental exposures that impact the neighborhoods in Baltimore City, that impact lung health, that would help you come up with a multi-pronged approach. So it's anything from better investment in the neighborhoods, dealing with the vacant housing, which are sources of, mouse, rat, cockroach infestation, dealing with air pollution sources. So there's a trash incinerator that is near Cherry Hill, which is one affected neighborhood in Baltimore, and there's been a lot of community organization about shutting it down. You can put scrubbers on air pollution sources that can be helpful. You can deploy portable air cleaners in homes that are helpful because outdoor air pollution penetrates indoors. So it's really a multi-level and multifaceted approach. There are lots of practical questions about political will, prioritization of problems in cities like Baltimore and Detroit that are really, really struggling with, a whole host of factors. So I don't have any good answers. I just want to emphasize the point that you made, which is that this does not obviate sort of the imperative to address the neighborhoods themselves that are affected.
Thank you so much.
Yeah. And if there are people who have thoughts about or policy experts, please chime in.
It looks like Shelley raised her hand.
Okay. Oh, thanks. I really enjoyed that, Elizabeth. I'm wondering if, in addition to the environmental factors, that there is some correlation with low-income areas having reduced access to kind of routine health care and more visits to the emergency room as their primary source of health care.
So potentially there is evidence that points to that. I don't think that is, I mean, obviously, I think that is not all of it. And I think there's another complicated concept that I want to describe here, which is that there's no question that minoritized kids living in poverty are way undertreated for their asthma, even though almost all kids, at least currently, are covered by insurance because of Medicaid. It's 90% in Texas, 95% nationwide. They all have primary care providers because at the moment you have to get vaccines to go to school and all of that. They are still undertreated. And so that's a huge issue. I always then turn it around and say, they may be undertreated because of the environments that they live in.
Yeah.
And so we are then, and I am not someone who, I have the kids that I take care of who need to be on inhaled corticosteroids are on inhaled corticosteroids. I prescribe biologic agents to control their asthma. But what I am hoping that the clinical community understands is that it's critically important for those kids who are undertreated to appropriately treat them in terms of a medical management perspective. But in the back of our minds, we should be recognizing that we are treating a structural and environmental problem, with inhaled corticosteroids. So there's absolutely undertreatment. We need to fix it because that's what helps kids now. We have really effective medications. They have very few side effects. Super important to do. But the undertreatment is probably, it's an access issue, but it also wouldn't be an issue if they were living in different neighborhoods. So I forgot to mention also that when these kids moved, their medical management didn't change, and they were actually on less inhaled corticosteroid or inflammatory medicine. So it wasn't that their medical management or healthcare access improved and that was what mediated. In fact, they needed less medicine overall.
Thanks.
Yeah, that's a great point.
Elizabeth,
Hey.
thank you. I love the way you told the whole story and all the pieces together. And I was I was a little surprised at I guess it was the discrimination and social cohesion findings. I would have expected maybe those to go up and not down. So I was just curious about like how those are measured or what your thoughts are about that.
So there's a discrimination questionnaire that we use, and I can't remember specifically which one it was, but it is, I think, one of the commonly used, validated to some extent questionnaires. And then similarly with like social cohesion, and it asks questions about do your neighbors get along? Do you trust your neighbors?
Mhm.
Those questions were sort of this afterthought for us to add on because there are no, well, we had a sociologist who was a co-investigator, but she was not super involved in a lot of detail, and that's not our expertise. So we saw we saw that they didn't change, but there are groups of people, and I'm blanking on her name, who takes a qualitative approach to studying these families who are in the housing mobility programs to take deeper dives into their experiences related to, if you are Black and you move into a neighborhood that's predominantly white and better off, what are your experiences like? And you've left your community, et cetera. So there's always been some concern about that. I think some people have found that to be the case in some of these sort of more in-depth qualitative studies. We did not find that to be the case, but just with these kind of two instruments. Stephanie DeLuca is her name, Stefanie DeLuca. And so she had a book where she followed, I think, some of these families over time who moved. And that gets to Jay's question, right? Like the best thing to do is to be able to feel like you can stay with your community that's supporting you in a healthy environment. I know it's overtime.
You're fine. We had it set till from 10:10 to 11:10,
Okay.
so you're good. Were there any other questions for Elizabeth? All right.
I'm interested. Do you know if people are thinking about your work in ways that have to do with like litigation, reparation, damages, like class action,
Um, in terms of
response?
like, so now that we've found this and published this, now whether there's an opportunity for lawsuits about health damages.
Mhm.
That's
I
super
mean,
interesting.
I have a colleague in North Carolina who did a lot of stuff about this. Alan Parnell. Do you know Alan?
I
He's a
know the name.
sociologist. They did some really amazing work with some communities in North Carolina mapping, redlining, but clean water,
Right.
and showing the patterns of civic, literal financial investment in infrastructure and essentially documenting the incredible racism and patterns of access to equitable water that led to a major
Right.
lawsuit and renovation of the city's infrastructure, physical plant infrastructure to redress historic, systematic wrongdoing. But I don't know if
So I wonder, so one of the things that we're trying to pursue, a friend and colleague of mine, Corinne Key, she led a submission of a U01 to NIH where, and I didn't talk about this, but sometimes when I give this talk, I do, where we've looked at this through the lens of once you have asthma, is your asthma worse because of, I'm just going to use neighborhood as a large term for all of this mess. There's another question, which is that if you're born into these neighborhoods, does it increase your risk of developing asthma? And so in this U01 proposal, we proposed basically to look at housing, there are many aims, but one of the aims is that when you look at all of the housing mobility data from BRHP, we're going to link their data with Medicaid data. You can identify kids whose mother moved and then they were born, or who was born in the old neighborhood and then they moved, with the question of, for kids who were born after the mother moved into the opportunity neighborhood, is their risk of having asthma or developing asthma lower? And that would be a game changer because we've never ever prevented the disease. We have nothing to do to prevent the disease. And we have a whole body of evidence that says childhood asthma is a risk for developing COPD, et cetera, in adulthood. So I'm just speculating that if you're looking at water and you're thinking about lead or other contaminants, that you may have a stronger legal case because it's causing damage that is permanent. We are showing that you have more asthma exacerbations, and you could try to make a case that that's permanent, but we haven't actually shown quite yet with, that they're long-term irreversible impacts. And I wonder whether, from a legal perspective, that's where the strongest argument. And so we may be in a position, to provide that kind of data, and that maybe, because that would be fantastic, because that's exactly, I don't see any other way that change will happen.
And it loops back to Jay's point about like, well, we can move people around all we want, but if we don't have, just infrastructure and right. Thank you. It's an incredibly complex and beautiful story. Thanks.
Well, thanks for the opportunity. I like to talk about it, and especially with different audiences. I'm going to my allergy conference tomorrow, so it's like a totally
Thanks.
different.
Awesome.
Yeah.
Great to see you all.
Yeah. Thank you. Have a good day, everybody.
Thanks, guys. Take care.